Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first session of today is our honorable guest from Uruguay, Prof. Alvaro Cordoba. Prof. Cordoba is a consultant neurosurgeon in the Department of Neurosurgery, Montevideo, Uruguay. He is a fellow vascular neurosurgery at the AKH Neurosurgical Clinic, Medical University of Vienna, and Faculty of European workshops on cerebral revascularization. AKH Neurosurgical Clinic, Medical University of Vienna, Australia. His clinical interests are focused upon neuroendoscopy, neuroanatomy, restorative neurosurgery. He is a president-elect and active member of the International Board of Federation of Neuroendoscopy. He was also a member of the WFNS Committee on Neuroendoscopy, past president of the Latin American Society on Neuroendoscopy, and he is an active member of the Austrian Society of Neurosurgery as well as the faculty of the Walter Dandy Society. We are extremely honored to have him today at our webinars, and today we'll be talking about 4 uncommon aneurysms and surgical approaches. The speaker for the second session of today's webinar is our honorable guest from China, Professor Zhang Shen. Professor Zhang's research efforts focus on patients with cervical spine conditions including CVJ malformation, cervical spondylosis, cervical OPLL, cervical spine, and spinal cord tumors. He is a principal investigator of the cervical spine research program and directs a laboratory specifically studying anatomy and biomechanics. He also devotes himself to clinical and translational research and the goal of applying his findings to new treatment for patients. He has published more than 70 peer-reviewed articles and has presented his research at dozens of international and national conferences. He has served as a member of the Spine Committee, WFNS, and is an executive committee member of the Craniovertebral Junction Society, and he is a vice president of the Spine and Spinal Cord Committee of the Chinese Congress of Neurosurgery and an executive committee member of the Chinese Association of Neurological Surgeons. We are extremely honored to have him today with us, and he will be talking about surgical treatment of upper cervical chordomas. The chair for the first session of today's webinar is our honorable guest from Taiwan, Prof. Sanford Su. Prof. Sanford is a director in neuro-oncology, cerebrovascular and skull base at the Neurological Institute, Taipei Veterans General Hospital, and is also the associate professor of National Yang Ming Chiao Tung University. He is a visiting professor at the University of Virginia, and he was the vice secretary of the Taiwanese Neurosurgery, Neurospine Society, and Taiwanese Neuro-Oncology Society. He was a former fellow with Prof. Ali Krish, Prof. Al-Mafti, and Prof. Yasha Gill. He is a noted author with several publications in various peer journals and book chapters. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Portugal, Prof. Oscar Alves. He is the head of neurosurgery at the Hospital Luciados, Porto. He is a consultant neurosurgeon in the Department of Neurosurgery at the Centro Hospital de Gaio Espino, and he was a previous Fulbright Fellow. He is a co-chairman of the International Academy of Spine, and his clinical interests are focused upon spinal diseases including spinal tumors and degenerative spine disorders. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Prof. Sanford Su.
Thanks, Raja, for the introduction. This is Dr. Sanford, and this first speaker will be Alvaro Cordoba. He is from Department of Neurosurgery of Montevideo, Uruguay. Today, he would like to talk about the 4 uncommon aneurysms, and we are expecting to his lecture. And please, Professor Cordoba.
Thank you very much, Professor, and thank you very much, all the professors. Thank you so much for the introduction. I will try to show all of the 4 cases. They're very interesting because in all of my life in vascular surgery, this type of surgeries in this kind of aneurysm was very, very incredible for me. And I will show you very interesting 4 cases. Thank you very much for the introduction also, and my second opportunity here, because the last time I have technical problems. I hope that I have no in this situation. The first case is very interesting because normally the aneurysms in childs under 1 year of life, they're extremely rare. So it's difficult also to recognize, to make the diagnosis, and then to how to try to solve the problem. It's very, very difficult because despite the huge increase of endovascular treatments over the world, Actually, there are no concerns about the experience in childs in endovascular procedures. So it's very, very difficult to decide if we try to compare in adults, which is the effect of the endovascular and the surgical approaches. This is very interesting. Sorry. This is a 8-month-old female that suddenly suffer with intracranial pressure and with seizures. This is very common, and this is the most common symptoms normally at this period of life when occurs intracerebral hemorrhage or, for example, subarachnoidal hemorrhage. We start with coma, with Glasgow Coma scale with 8, with light and corneal reflex, and with intracranial hypertension, in very critical conditions. So we tried to study, and we saw a very huge intracranial fissure for hemorrhage, subarachnoidal hemorrhage with an hemocystern and a right hematoma. So we tried to decide to study with CT angio, and in this part, it's possible to see a very complex aneurysm. You see neck, in part neck aneurysm, and without neck, completely non-regular aneurysm, and non-saccular parts. So we see a lot of branches of the sylvian M3, M4 portion of the sylvian artery, and the inferior branch of the sylvian artery is also compromised. So it's very difficult to decide how to proceed, despite we have an hematoma, an hemocystern, and intracranial hypertension that we need to open the skull, obviously. But then we try to solve at the same time the aneurysm. So we decide to approach in order to evacuate the hematoma, in order to try to improve all of the intracranial pressure, and then try to solve and to explore what is possible to do with this kind of aneurysm. You see here, this is the common angiography, and it's very clear the type of the lesion, and it's difficult also to try. We ask also to the endovascular, but I repeat that it's not so common to treat by the endovascular way this kind of childs. We have we see it's possible to see a lot of series that describe this kind of lesions. Also, 1, 2, or 3 months years old, but all they are proceed with surgical approaches. So this is okay. This is another, and then here we can see in the much increased approach in the angio-CT, and this is a angiography, and it's possible to see only one part with something like a neck, and the other with a completely dysplasic aneurysm. So it was very difficult to decide also during the procedure. So we try to clip this part of the next part of this complex aneurysm. Sometimes we compare with a dissecant aneurysm, but it's not so clear also in these kind of regions. So we try to clip, evacuate. We see very clear the branches of the inferior branch of the sylvian artery. It was possible to clip this part, and then with use 2 clips fenestrated in order to preserve the inferior branch of the sylvian artery. So you see here, it's very clear. You see the sylvian artery with the inferior branch, and all of the aneurysm around was clipped with curved and semi-curved clips in order to preserve all of the branches around. The problem is how to proceed with another part, because there's something like dissecting aneurysm around of this sac of the neck near to the aneurysm is very difficult to solve. Normally, we try to use, like in the past, the wrapping technique, clip wrapping technique, but the material that we are using a long time ago is Gore-Tex. We prefer this kind of materials because they develop less inflammatory reaction around of the arteries, and it's very important because one of the cases that I will show where I will see another material used and was a terrible reaction, and the name is textiloma or mucinoma. This normally is possible to see and to describe. So we put the Gore-Tex here around of the part that was not possible to clip, and then we try to preserve the inferior part of the sylvian artery. So we see here, it's possible also to see with ICG in intraoperative procedure. The ICG, I think, is very useful sometimes. Sometimes it's difficult to see all of the details in the deep of the images, but you see here, if you compare with the upper picture, very clear the clips. The filling of the inferior branch of the sylvian right sylvian artery. So it's very clear. You see here. We try to explore very carefully. We try to retract a little bit. And we see very clear the filling of all of the branches that you compare in the upper part of the screen. You see clear the picture that this branch of the sylvian artery were preserved. You see here, this is the pre-op, and in the right up, it's possible to see the post-op. You see the aneurysm completely solved, unfortunately for the child, and you see the inferior branch of the sylvian artery preserved. So we feel very happy about that. The child was very nice, and actually is in very good condition. Because normally it was 10 days in the intensive care unit. We did MRI and CT control. We saw also, despite this very good, nice procedure that commonly we see in the subarachnoidal hemorrhage surgery or endovascular, a mild ischemia near to the sylvian territory, but was discharged of the 15th day with mild left brachial paresis. Actually, it's completely solved, recovered, and it is a common and very normal child doing very well, and we feel very happy about that. One of the earliest recorded cases of childhood aneurysm was in a 15-year-old boy reported by the German pathologist Eppinger in 1971. It is very interesting. And normally we see, it's possible to see, normally very huge problems with collagen pathologies in vascular diseases and connective tissue disorders normally in childhood. This is a reason that we have see a very complex type of aneurysm, not saccular in part, something like dissecting aneurysm, and we must to check in all of the life of the child, because it's possible to see different kind of vascular lesions in different part of the economy. Normally, in the part of the, for example, in the heart, normally in kidneys, and it's possible to see in different parts. So it's very interesting to see that. Normally, the enrollment of small fetal cerebrovascular networks mature to form for the adults system in transform of the major arterial trunks. That is very important. But normally, such vestigial of this part, incompletely aborted navins could become progressively dilated to the aneurysm over the time. That is the main concept that we have. We must to take in mind about that, because this child, despite of solve at this period, this aneurysm, is possible to see another aneurysm in the future. So we must to check this child at least once a year or perhaps every 2 years. The incidence normally in this kind of childhood is 3–4%. Normally it's 1 to 3 cases in childhood, aneurysm 1 per million population. So of the children with aneurysm that rupture, this estimated mortality is very high. It's 11 and 20% as compared to 20 to 30% in adults. So it's possible to in 7% to rebleed with a subsequent normally 25 mortality rate. This have a high mortality. And the very interesting thing that is normally the only symptoms that we can see is seizures only, and with compromise of the consciousness. So when we have this kind of clinical symptoms, clinical case in the childhood, we must suspect an aneurysm with an rupture, intracranial rupture, and normally it's very severe pathology with subsequent more than 25% mortality rate. So we must to treat. The problem is actually that it's not possible to compare the minimal invasive approaches, but sometimes there are not so minimal invasives because the pathology is a very bad pathology despite the procedure that we can choose. Seizures that is possible to see, and we talk about that. The onset is typically sudden with headaches, vomiting, and deterioration of consciousness. But seizure is the principal symptoms with coma, paresis, and a lot of things that is possible to see in adults. So it's possible to see sometimes from the silent form of bleed, like in the adults. But seizures, normally we start with the main symptoms of this kind of pathology. A review of the literature, so the direct clip ligation of the aneurysm neck is possible only in normally near to 30%. And a high percentage of pediatric patients require specialization and often innovation procedure to obliterate the lesions. So it's possible also to solve by surgery, but actually it's not so easy to solve all of the cases. That is the reason that we employed the combination of clip wrapping. Mainly the using was Gore-Tex, that was surprisingly was very effective with a very low inflammatory reaction in order not to block the another branches of the cerebral artery. So it's very interesting to see and to take in mind this kind of Gore-Tex clip wrapping that is safe and useful. Normally, the rapid and de novo aneurysm formation after clipping in the middle cerebral artery aneurysm in the infant is possible to see with a gene mutation MH11. So it was described that it's not only a vascular lesion alone. It's have a lot of genetic problems. That this is the reason that we have to check at least 1 or 2 or every 2 years this kind of child in order to see what happened if develop a new de novo aneurysm or not. This is part of our literature that we try, it's possible to use the efficacy of clip wrapping in treatment of complex pediatric aneurysms that was described in 2012 in child nerve system. And it's very interesting. The second case was also very interesting, that is an adult. Normally, it's not so easy and not so frequently to see this kind of lesions, and normally it's not so easy to approach. This is the case, there are 45-year-old men with very severe traumatic brain injury during a street aggression. Normally, the common Glasgow scale was 7, with bilateral frontal bone fractures, with mild bone depression, with mild frontal right contusion, a lot of severe anterior skull base, orbital, ademoidal, and sphenoidal fractures with compromise of the internal carotid artery. At approximately 1 week after, in the intensive care unit, present has very severe epistasis with massive bleeding, and was very important to perform the emergency tamponade and occlusion of the nasal cavity and the sphenoidal cavity by the NT surgeons in the intensive care unit. So they put intranasal compression with Nelaton catheters, with inferior turbinates, fat and flocil, and unfortunately for the patients, they stopped the bleeding that normally is mortality is more than 60%, 80% during this episode of this period of the bleeding. Then they tried to explore 1 week after this situation, and the NT surgeon explored with the endoscope by the endonasal approach, and they discovered the type 2 right internal carotid artery post-traumatic pseudoaneurysm developing in this part of the carotid artery. You see here in the picture a very huge lesion, complete cover around of the surface with a lot of materials, but it's very clear that develop inside of the right sphenoid sinus a very huge pseudoaneurysm internal carotid artery in the sphenoid portion of the internal carotid artery. You see here in the DCA 3D angiography, very clear. You see a normal part of stenosis of the internal carotid artery. And the thing is in this part is how to proceed with this kind of lesions. We asked to the endovascular also, but the problem that we saw, you see here, the lesion is very clear, but we have a stenosis near in the part of the MRI is very clear in the left, but the DCA is much more clear. And you see here a very huge stenosis that is not possible to pass across of this stenosis in order to avoid ischemia or avoid a blockage of the flow of the internal carotid artery. So what can we do with that lesion? And we decide to approach for the first time, at least try to explore by endoscopical endonasal approach. And we saw it's possible to try to solve by this approach. We discover also the internal carotid artery in the neck, and we try to work under monitoring in order to see what's happening. We need to try to ligate the internal carotid artery in the neck. So it's very difficult also to decide this approach and this kind of lesion and try to solve this. You see here. We planned 3 or 4 surgical strategies. Internal carotid artery occlusion is one of the much common, very ancient. Perhaps we perform or not, despite of the carotid occlusion, the internal carotid artery and the intracranial bypass. It's possible to make the direct approach, and also the endovascular was the last. We asked to the endovascular, but you see here in the picture on the right, the problem was the stenosis. So they tried to refuse to do that, and we continue with these patients alone. It was very difficult to decide. Doesn't matter. You see here the MRI, a very huge lesion in the right sphenoid sinus, within the surface a lot of materials that we put the NT surgeons in order to save the life of the patient. And we proceed to discover at the neck the internal carotid artery. You see here, very interesting, under continuous monitoring. And we're trying to dissect in order to obtain the proximal control. The anti-surgeon exposure time with the first, and they will continue with the neurosurgical approach and endonasal and neuroendoscopical approach. You see here the lesion is very interesting. It's a very huge lesion. We try to explore in the right sinus in order to dissect around, and in order to it's possible to discover or not, it's possible to clip. And in tandem normally, because we need at least 3 clips. But the main situation is trying to discover where is the neck or something like the neck, because it's a pseudoaneurysm. We tried every every time. You see here, in order to dissect carefully around. The first clip was the much more important. You see here the image during the approach in a very huge cavity. It's very interesting that the endoscopy in this kind of approach is very useful. You see here, we try to explore very carefully, and we see here also very short videos. The first clip was the first, much more important. You see in the upper part something like the neck, and in the second part also the same image. We always use the endoscope, a dissector, and aspirator with the assistant. And the much more important thing is how to imagine where is the three-dimensional concept of this kind of lesions. Because where is the carotid artery? It's behind on the upper part, and where is the neck, or something like the neck, it is possible to start clipping in tandem procedure. You see here, you put the second clip in the upper part. That is very nice image you see here. And we try with the last and the third clip, that is possible to do that. Here also we see when we put the last clip, that is possible to attempt to resolve this kind of lesion. You see here. Unfortunately, the surface of the aneurysm is very strong, was very strong, and we have no problems with bleeding. But this is a very huge, very big problem if you have. But with the discovery of the internal carotid artery in the neck is very important. Then we use also the Gore-Tex, you see here, in order to put and to cover with like wrapping, in order like the first case that we show, that's possible to cover, not to develop new lesions of the novo aneurysm. That is very nice procedure. Yes, the angiosity post-op. Unfortunately, we solved the aneurysm. And in the right, we see a schema that's very interesting to see all of the very interesting anatomy. We must to think that we are working in a surface no more than 2.5 centimeters. We have a lot of structures, both carotid arteries, a lot of fractures also, a lot of structures in nerves, arteries, small arteries, a lot of things. That is very difficult to work in this field. But in this case, neuroendoscopy was very useful. And unfortunately, the patient is in very good condition. You see here, unfortunately, it's a very good condition. And they solve a very difficult lesion to treat, very huge and high mortality. You see here two types in schematic illustration of type of sphenoides pseudoaneurysm. You see here type 1 and type 2. In this case, was not possible to treat by endovascular, so endoscopy was very useful. And you see here in at 1 year the MRI angiographic control. Normally, the intracranial aneurysm is a pseudoaneurysm. It's a very rare entity and represents about 1% of intracranial aneurysm. You see a very huge lesion around part of the bone, and then develop a lesion like a pseudoaneurysm. The problem is the mortality is very high, more than 50 and 80%, and this lesion must to treat very soon. So it's very important to take in mind that despite the way endovascular or surgical is, we must to treat this kind of lesions. They are much more common. They are traumatic lesions. There are then iatrogenic infection diseases, radiation exposure, connective tissue diseases, and sometimes it occurs spontaneously. That is normal, much common after trauma. That is very interesting to take in mind. It's a really false aneurysm and corresponds histologically to external lumen that develops into a surrounding hematoma following disruption of layers of the vessel wall. That is the main concept that we have in mind and we must take in mind. And another one is mortality is high, it's up to 50%. So we must treat this kind of lesion very, very soon. And epistasis normally appears suddenly and normally compromise the life of the patient at his home and also in the hospital. So these lesions, they must treat very, very soon. This is part of the literature. It's possible to describe a lot of things, a lot of procedures, a lot of topography from, for example, MCA, from the polar, internal carotid artery, despite ICA also, but the etiology is very, very huge. Radiation, traumatic, you see a lot of things. This is normally the literature that is possible to see. But the direct clipping of the aneurysm normally or sometimes is not possible. So we must treat by the endovascular if it's possible, but they are much more safe than sometimes, and it's possible endovascular to try to do that. The problem also with endovascular, perhaps with flow diverters, actually they are very nice to do that and to try to solve in order to avoid the stenosis of internal carotid artery. So normally the advantage of selective pseudoaneurysm embolization is the preservation of the parent artery. And this is a problem that we have. There's no so safe to preserve the parent artery due to this kind of stenosis, despite this possible a flow diverter or a stent. So we decide to approach and to solve surgically. So it's possible also sometimes to put coils, but they are not so safe. And normally the infection of the thrombus during the coil, normally and the flow and pulsatily may force into the interstices and the coil mass and lead to recurrent bleeding. So it's not so easy, and we have no the best choice to select to proceed this kind of patients. So we decide to do surgically. In conclusion, in these cases, it's normally with patients with head trauma who present with sphenoidal senus fractures with or without massive epistasis should be evaluated for the development of traumatic pseudoaneurysm as soon as possible. And it's possible to, despite, we must treat very, 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 very soon. The third case is very interesting also because it's a very complex aneurysm, multiple aneurysm, and we use the technique of the click wrapping and mucinoma in complex aneurysm develop. Mucinoma is a very huge and very ancient complex. They normally derive from the concept of the use of wrapping with mucinomas, and then it's possible to put mucilin inside a long time ago. So we prefer to use with a very low inflammatory reaction the use of Gore-Tex, because if you put different kind of materials during the clip wrapping, you develop in the future a very huge inflammatory reaction with the block of the arteries. This is the case of the 48 all-females with progress decrease of visual acuity in the left eye and with headaches. We did MRI, CT scans, also visual fields, and we see a very huge aneurysm in this part combined with a small aneurysm, multiple aneurysm in the area on the anterior part of the Willis polygon. You see here. This is the lesion, very huge in the internal carotid artery near to the visual nerve, optical nerve. And sometimes it's possible also to treat by the endovascular, but what the same like the last case. It's not so easy because sometimes it's possible to use flow diverters, but sometimes you have a complete block of the internal carotid artery. You see here, this is approach, you see the lesion, and it was not possible to clip because it was not easy to recognize the neck of the aneurysm, and we decided to put different kind of materials. These are during the endarterectomy materials, patch of materials that used by the vascular surgeons. We cover all of the surface with this kind of material. And you see here, this is another material that's not Gore-Tex. This is a patch of normally with an endarterectomy used by the vascular surgeons. You see here. And then progressively they develop as normally occlusion, progressive occlusion of the internal carotid artery during the reaction, of the inflammatory reaction. And you see, this is the pre-op visual field. And we see that, very interesting. You see at the 6-month control, reduction of the aneurysm, despite they conserve a small amount of the aneurysm, is not the same. You see here, they are blocking progressively, but blocking progressively also the carotid artery. It's like a ligation in the neck, but this is they develop in this region. So it's very interesting to see how the inflammatory reaction from outside of the arteries is something like the endovascular procedure from inside. It's the same thing that inflammatory reaction sometimes occurs is in order to block or in order to interrupt the flow inside of the internal carotid artery. You see here, 6 months, 1 year after the surgical procedure, completely thrombose the internal carotid artery, but unfortunately we have a cross flow that is possible to conserve the vascularization of the contralateral part. So we have not more the aneurysm, you see here. This is a MRI angiography. It is very interesting to see. Also here you see completely blocked the right internal carotid artery due to the inflammatory reaction without the use of clipping. That is very, very interesting. Unfortunately, I repeat, we have a cross flow from the left with complete filling of the contralateral side. This is normally the visual field that they improve a little bit, but no more. And this is the concept of clip wrapping. Clip wrapping is possible to use all of the round of the aneurysm, put the clip in order to make the wrapping in the place. And normally we see a vascular reaction, inflammatory reaction in the wall of the artery. That is very important to see. The histopathology revealed mononuclear clear cells infiltration and fibrosis formation around the retinial material. And this is very important because normally it's a very huge reaction. You have a complete block of a lot of arteries around, and they compromise also the brain tissue. So we decide to use Gore-Tex because normally all of the hemostatic elements that are introduced in this kind of pathology conduce an excessive inflammatory reaction. The Gore-Tex in this situation is a very, very low material. It's really useful in trying to do that, the ancient technique of the wrapping. If you combine with the clip, we found a very, very nice, really very nice procedure to do that. Normally, all cases of resorbital and non-resorbital hemostatic agents may produce textiloma. And the concept is that textiloma is an allergic response to this kind of material. And the textiloma may present with neuroimaging features that might make recurrent tumors, abscess, and hematoma. And sometimes possible to reoperate in order to remove this kind of huge lesion, like a tumor, like an abscess, or like an hematoma. So normally, all of the substance that the foreign bodies we put inside of the brain is possible to develop a very huge inflammatory reaction. In one part, they are useful for vascular procedures, but in the other part, the behavior is like an hematoma or like a tumor. So it's very important. But in this case, the result of the trying to solve this kind of aneurysm was very, very interesting. We have the bibliography here. in neurocervical reviews normally, but a long time ago, 2010. And the multilinoma as muslin-induced foreign body inflammatory reaction was very, very huge study a long time ago. Much more citations of the you see here in the bibliography. And this is a concept. The first Muslim wrapping was reported in 1978 with catastrophic loss of vision. That is the problem, which we are very close around of the visual field and optic nerves. Normally, they compromise with the very huge inflammatory like arachnoiditis, and normally they are a very catastrophic loss of vision despite you solve the aneurysm. That is the concept. And normally it's possible to see also rebleeds more than 50%. So it's very, very, very difficult to consider alone the wrapping like a procedure. They are very, very important bibliography to see in the clipping using sling ramp method, for example, with polyglycolic acid is one example. But I think it's very important to take in mind. You see here the Goretex. In this patient, we discovered a very small aneurysm also. It wasn't possible also to clip because they are very, very difficult to compromise or not the sylvian artery. And also we cover the surface with Goretex. You see here around like a crown in the upper part of the aneurysm. And this is the post-op. Actually, it's completely stable, the aneurysm, more than 10 years after. And the patient is in good condition. So normally we use EMA shield, like the collagen impregnated dacron fabric, but this is the very huge inflammatory reaction. So this is the reason that we try to like the dacron patch inflammatory reaction in the endarterectomy. That is very important to select this kind of materials, and we decide to use here the Goretex. Normally the bleeding after the wrapping occurs in 12%, but I think that is much more 20-25%. So normally granuloma formation was observed in 1.5%, and normally it's possible also to report much more increase. So we have a lot of huge bibliography about that. But this case, I think is very, very important, very, very nice to see how to thrombose progressively, like ligation in the neck, if you compare the internal carotid artery. You see here. And the last case is very interesting also. We saw this patient with a very huge meningioma, sylvian fissure meningioma and carotid bifurcation aneurysm. That is a very not so frequent combination, but it's possible to see with, because during the meningioma arteries, you have a very severe alteration of the wall of the arteries, and it's possible to develop in combination with the meningioma. It's possible to see also the aneurysm. In this case was one of these cases. You see here the topography, and you see the aneurysm in the bifurcation of the right internal carotid artery. And you see here how to proceed. The thing is, we must, for the first time, try to remove very carefully the meningioma, and then try to solve in the deep of the lesion, try to clip the aneurysm in the bifurcation. Another way is to proceed in the vascular and try to solve first the aneurysm, and then to try a much more safe procedure, try to try to resect the meningioma. This is an schema and the image in the superposition of both images. You see here the approach, the sylvian approach, and you see here the meningioma, and below the meningioma, the internal carotid bifurcation, and all and the aneurysm that we did. You see here. Here is the video. We start with a dissection of the sylvian artery, and then try to the resection of the arteries very carefully. You see here, it's a typical meningioma. And we try to proceed with the anterior part because in order to dissect very carefully the sylvian fissure, in order to dominate the internal carotid artery first, and then to proceed near to the bifurcation of the carotid artery. So, unfortunately, with the approach of the meningioma, we have a very nice surface to dissect, very nice, very clear to separate all of the tumor from the structures around, and near to the sylvian fissure. So it's possible to dissect the artery. You see here the aneurysm. You try to dissect from the neck, and then it's possible to try to dissect from all of the perforators. You see here, and then finally we try to clip the aneurysm and to preserve all of the branches. At least for in our experience, for the first time that we saw this kind of lesions in combination with meningioma, but in the literature, they are very, not so frequently, but it's possible to describe because this is one of the reasons that we have a lot of problems in the wall of the arteries near to the meningioma, and it's possible to develop aneurysm in combination in the same side or contralateral side of the meningioma. So this is part of the bibliography. It's possible to report that 70 years old lady with this kind of lesions. But it's possible also to see 1% of aneurysm and meningioma, they are in combination. We can be treated by clipping or culling. It's possible also to make combine or separately. The vascular malformation of the tumor capsule and surrounding arteries are on the basis of the aneurysm, dysplastic vessels. This is the reason that we can find, or we found this kind of aneurysm near to the meningium. Okay, thank you very much for your attention.
Yes, we thank Professor Cordoba for their excellent speech for these very interesting and rare cases. And I have several questions for Professor Cordoba.
Yes.
The first, you mentioned in the first case and the third case, you would like to use the clip wrapping techniques for complex aneurysm, and sometimes you use cortex.
Yes.
But do you have any experience to using the muscle? Sometimes we will harvest muscle, and
yes.
we usually like it as cortex. And
yes,
yeah, do you think there's less information process when you use muscle than the cortex? And also the muscle is fit to the contour of the aneurysm.
Yes, that is true. We have a lot of materials. Muscle was one of the first uses that is much more biological materials. It's possible also to use, but we prefer cortex. But because if you use also muscle, we will have a very huge inflammatory reaction. And the problem is when you have a very huge around the aneurysm, it's possible to compromise the arteries around, and also it's possible to compromise the nerves and a lot of structures. You need not to develop a huge inflammatory reaction. It's much more not so aggressive material, and I think cortex is very nice to use. I learned that about the vascular surgeons because it's not so easy. But I think all they are valid in our field. All the things are valid, but the experience show that when you're a little becoming older in this discipline, and it's possible to learn about that. It's possible to select this kind of.
Yes, and for the first, second case, the very rare spinal sinus joint aneurysm, and actually, when you try to clip such kind of aneurysm, how can you prepare for the proximal control, even for distal control?
Yes. This was a very difficult case. I prefer for the first time for endovascular, but the problem was the stenosis in the carotid artery, and I have two ways to approach. I think I thought about two ways to approach. Starting for the non-nasal approach because it's a minimally invasive, but we plan also to go to a transcranial approach in order to control the distance. Unfortunately, we have a very nice result, but we must take in mind all of the possibilities during the procedure. You must, for the first time, to have the most important proximal control, and we will see it's possible perhaps to do that in this way. You can change also, and you must to be prepared with a lot of things, also with intracranial bypass.
And for the last case, when you do the meningioma resection, as you know, the aneurysm is in the subarachnoid space. And for the meningioma, we do the meningioma resection. Usually, we try to find the arachnoid plane to keep the arachnoid plane intact by side of the normal anatomy. So in this case, can you find the intact, or can you find the arachnoid plane between the tumor and the aneurysm?
Yes, it was very interesting, and this is the reason that we decided to do for the first trying to dissect like an aneurysm approach, to dissect the subarachnoid space near to the carotid artery, and then go and then we went distally to this part and discovered a very nice plane, a very nice surface to dissect separately to the aneurysm and the tumor. It was very interesting case in this way. That is very interesting to do.
Yes, thank you, Professor Chordoma.
A pleasure.
And thank you for your excellent speech. Thank you very much.
Thank you,
Yeah,
Professor.
thank you.
Thank you, Prof. Alvaro Cordoba and Prof. Sanfordso for this very wonderful session. We have one question in the chat box by Dr. Fahad from Bangladesh, who is asking, in the first case with raised ICP, do you use a lumbar drain or ventricular drain? If can't make the brain slack, do you send tissues of aneurysm wall of this case, as they are rarest of the cases?
No, normally we don't use. A long time ago, when they started, we perform every time lumbar puncture and lumbar drain is very useful, but actually not. We try to do the resection of the hematoma. We have enough space to proceed, and then we must to solve the aneurysm. Try to employ much more time in this lesion.
Okay, thank you. There are any questions from my co-host, Dr. Libun Singh?
Yeah, thanks, Raja. Thanks, Professor, for a very nice lecture. I have two questions, Professor. Your second case, that pseudoaneurysm in the cavernous segment, which are pointing towards your sphenoid sinus, and you aim for direct clipping. I believe in that case, there's no violation of the arytenoid plane. There's no CSF leak. In the cases that where you need to do durotomy with the clip, part of the clip in the sphenoid sinus, how can we do a proper dural closure? My second question, Professor, you show us the third case, clipping wrapping technique, and eventually induce thrombosis. Do we need to look for cross flow before we attempt that technique? Or if the cross flow is not there, I would bypass as a part of precaution technique. Thank you, Professor.
Yes, for the first time, I think we have not the problems with the close and the fistula, because unfortunately the NT surgeon put a lot of material inside of the nose for the first time. You saw in the picture a lot of materials around and the surface of the aneurysm. You see turbinate, Gore-Tex, or they put a lot of things in order to save the life of the patient. And unfortunately, we have not the fistula. This is one of the reasons. And in the second, you tell about that.
The wrapping eventually caused ICA thrombosis.
Okay. Yes. Well, for us was a very huge surprise, in order to be honest. But I think we must to check all of the possibility, and in order to take in mind with the bypass procedure. But this kind was very was not expected, this cross flow really, and was very surprised for us, in order to be honest. But we must to take in mind all of the things that if you proceed with a balloon test, for example, and the bypass is always one of the possibility to take in mind.
Thank you very much, Professor.
My pleasure.
Well, thank you very much. That was indeed a very wonderful session, and we learned a lot. Thank you very much, Prof. Cordoba, and
My
Prof.
pleasure.
Sanfatsu as well. We have an update from Prof. Subin that currently there are around 560 people who have logged in through WeChat, YouTube, and Zoom. So it was a great learning session for all the young neurosurgeons who joined in today. Thank you very much. Now we'll move on to the second session, and I would like to hand over this podium to our Honorable Chair, Prof. Oscar Alves from Portugal, who would say a short introduction and invite Professor Zanshen for his lecture. Prof. Oscar Alves.
Thank you so much for inviting me. I'm very honored to participate in educational activities of ACNS. And let me introduce you Professor Zanshen from China. We will talk about the surgical management of cervical chordomas. Professor Zanshen is professor of neurosurgery at Xuanhu Hospital in Capital Medical University, China. He's member of the spine committee of WFNS, and we had the pleasure to work with him on guidelines, on multiple educational events around the world. He's an executive committee member of Cervical Vertebral Junction and Spine Society, executive committee member of Chinese Association of Neurological Surgeons, and to my view is a world-class expert in cervical spine surgery. So I would just like to, then at the end of this presentation, he can comment on this case of mine, 45 years old female, neck pain. The MRI reveals a mass at C4, chest, CT chest, abdomen and pelvis negative, neurologically intact, and prior history of cancer. So, dear friend, please, we are eager to learn from you.
Okay, thank you. Thank you, Dr. Oscar, your kind introduction. Hi, I'm Dr. Chen from, this is my hospital. It's founded in 1959 in Beijing, and our neurosurgery department is also called China INI. It's China International Neuroscience Institute. We moved to this building in 2019. And today, let's talk about chordoma. It's a kind of the most common malignant spine tumor. And so this kind of tumor is a histological benign, but locally it's aggressive and very not sensitive to radiotherapy and chemical therapy. So usually reoccur after surgery, and it have several subtypes, and it's conventional chordoma and differentiated chordoma and poorly differentiated chordoma. For this kind of malignant primary spine tumor, usually we like to perform a total unblock, but if it's located on sacral region, it's possible to do this. We can sacrifice the nerve root below as S3 and does not give the patient any neurological symptoms. For this kind of patient, we can remove the chordoma totally, and we can cure this kind of patient. But if the tumor located in around the skull base, especially C2, C1, this region, it's hard to perform a block because the vertebral artery are located on bilateral side, so we cannot sacrifice by vertebral artery. And another difficult to do the surgery is it's hard to rebuild the anterior column of C1 and C2 because it's an irregular shape. And usually, if we use a mesh it's not so stable. And in 2017, our Chinese doctor reported the use of personalized 3D printed water body to reconstruct upper cervical spine and give a lot of very better resolution for this kind of reconstruction. Another difficult is how to choose the approach. And for upper cervical region, it's hard to expose from material. So how to use the appropriate approach, and we can expose the tumor effectively and give us less damage to this patient. Now we very few use this kind of transmandibular approach. It's too invasive. Sometimes we use a transoral approach, but most of our patients we use a high cervical approach. With this kind of high cervical approach, it's very little invasive, and we can expose to the skull base and to the condyle. We can expose that region. So use this approach, we can very effectively expose the anterior column of the upper cervical spine. So for the cervical chordoma, we have to choose a appropriate approach. And for the chordoma just located in C1 and C2, we use a post approach and combined maybe transoral approach or high anterior cervical approach. If the chordoma involved not only C1 C2 but also lower cervical spine, then we use a post approach combined with a high anterior cervical approach. And if the chordoma destroyed skull base and also C1 C2, we use just a post approach. I show some cases. This is a chordoma just located in C2, and it's a male, 56 years old, and it's a C2 chordoma. We just use a post approach and transoral approach to remove the tumor and reconstruct the upper cervical spine. We first with the post approach, we remove all of the posterior structures of C2 and separate vertebral artery bilaterally, and then with the transoral approach, we remove the residual tumor and the C2 vertebral body, and we use a personalized 3D printed process to reconstruct the C2 vertebral body. And this is another patient, also C2 chordoma. It's a male, 58 years old, and we can see the tumor is much larger and destroyed the C2 vertebral body. And we can first we use a posterior approach to remove all of the structures of C2, and in this case we also use a personalized 3D printed process to reconstruct bilateral lateral mass. With this method, we can build the stability more better. And later, we use a transoral approach to remove all of the C2 vertebral body, and with the 3D printed process, we reconstruct the anterior column of C2. And we even connected the anterior process and to the posterior part of the process. And this is another patient. This is more complex case. the patient is male, 64 years old. He has been performed posterior approach removal, perform decompression of the upper cervical spine, remove part of tumor, but the tumor reoccur after 1 year. And now we can find that the tumor has destroyed C1 and C2. So with the posterior approach, we removed the posterior structures of C1 and C2, and then with the transoral approach, I removed the anterior part of C1 and C2 and use this 3D printed process. We reconstruct the anterior column of C1 and C2. And if the chordoma does not located not only upper cervical spine, but also lower cervical spine, it's hard to perform this kind of remove this kind of tumor from transoral approach because we cannot expose the lower cervical spine with the transoral approach. So we always use a high anterior cervical approach to do this kind of to do the patient surgery. And this is a patient, male, 50 years old. He has been performed surgery 4 times, and the tumor reoccurrence. And we found that this was a big, large tumor and destroyed C2, C3, and C4. And we can on CT scan we can see the tumor is very large, and the multiple cartridge are running in the tumor. So before surgery, we use the CT of the patient to reconstruct to do the 3D printed processes, and then in the surgery, first with the posterior approach, I dissected the vertebral artery bilaterally and separated from the vertebral artery from the tumor. Because this is a recurrent tumor, so we remove a lot of scar and adherent. We separated the tumor piece by little by little, and remove the tumor from posterior approach. And then with a high cervical anterior approach, I removed the anterior column of C2 to C4. And this is we expose the anterior upper cervical upper face joint of C2. And I remove the face joint and expose the face joint of C1. We can see the vertebral artery is there. And we protect the vertebral artery, and then I remove of the tumor. And then we implanted the 3D printed process, and with the screws fixed to the C1 and C5 with the screws. And postoperative MRI showed that there's no residue of the tumor, and the patient recovered very well. And after 1 year, there's no recurrence of the tumor. And this is another patient, a male, 46 years old. He suffered recurrent of chordoma after 4 times posterior surgery because in most hospital, our doctors will do the posterior approach first, but because there's a lot of residue of the tumor, always the second tumor recurrent very quickly. And we can see as the tumor is so large, and the patient cannot swallow and breathe. So the patient has been performed the tracheotomy, and he can only drink fluid food. And from X-ray we can see the cervical spine are destroyed so severe, and C2 and C3 the water body are destroyed. And from CT scan we can see the vertebrae are enclosed by the tumor, and the C3 and C2 and C3 are destroyed. And in the operation, first we perform posterior approach, remove all of the posterior elements of C2 and C3, and dissect the vertebrae. This is the first joint of C3. And we expose the vertebrae. There are some small vessels feeding to the tumor. This is the C2 nerve root. To remove the tumor totally, we cut open the C2 nerve root, and we separate the vertebrae and remove the tumor from posterior approach piecemeally. Because a lot of small pediatry, there's some bleeding, so I have to suture the very small broken on the vertebrae. And we separate the vertebrae from the tumor. And we remove the first joint from posterior approach. We cut the C2 nerve root bilaterally and separate the vertebrae on bilateral side. And then in the second step, we use high anterior cervical approach to expose C2 and C3 anterior colon. First, we find the interdisc space, vertebral space of C3 and C4, and remove the tumor and the anterior colon of C2 and C3. We remove the cartilage between C3 and C4, and then we implanted the 3D printed process between C1 and C4, and fixed with screws. After operation, we can see that the internal fixation system is in good position, and CT scan showed the 3D process contrast the C2 and C3. And after surgery, the patient receive cyberknife treatment. And 3 months after operation, we can see there's almost no residue of the tumor, and the cervical spine are recontrasted in good position. And 3 months after operation, the patient recovered very well with neurological symptoms. And this is another patient. He suffered upper cervical chordoma. He has been performed operations 1 month ago, and this is before the first operation. We can see the chordoma just located in C2. But first operation do not remove the C2 vertebral body and just remove the part of tumor. And this is after first operation. We can see the tumor are removed almost all of the tumor, but the tumor in the vertebral body are not removed. And this is exo view showed there's no almost residue of the tumor. And in first operation, the doctor also performed a posterior internal fixation. But 10 months later, the tumor reoccurred, and we can see the tumor is much bigger than before operation, and even larger. Axial coronal view showed the tumor is very large, and the CT scan showed now the tumor has destroyed C1, C2, and C3. All of the upper cervical spine is destroyed. And for this kind of recurrent tumor, first we do post approach, and we remove from lateral side, we remove most part of the tumor. And then on left side, we remove all of the posterior structures of C1 and to C3. But we preserve the transverse foramen of C1 to protect the vertebral artery. And then this is the anterior posterior approach first. We separate the vertebral artery on left side above C1. And then we separate the adhesion between the dura and the tumor. And we remove tumor from left side. And then we remove the C2 face joint, upper face joint. From left side, we remove almost all of the most of the tumor, and we remove the C1 lateral mass on left side. And on right side, we separate the vertebral artery. And we cut open the transverse process of C1 on right side to preserve the vertebral artery. And we remove C1 lateral mass. And we perform the posterior internal fixation to stable the CVG region. And from CT scan, we can show that we remove all of the tumor, and we only left very little part of water body between C1 and C3. And with the posterior internal fixation, we enhanced the stability with a 4-rod system. And this is a coronal CT scan. Show that there is only very small part of what body is left. This is after posterior surgery. The MRI showed that there's almost no residue of the tumor. And then in the second step, we like to perform anterior approach to remove all of the bone structure between C1 and C3 and reconstruct the anterior column with a 3D printed process. And we designed the 3D print process. In the upper side, we fixed the process into the occipital condyle, and in the lower part, we fixed it on C4. And this is the second operation, anterior procedure. We use upper anterior cervical approach to expose C1 to C3. And we remove the 3 wet body piecemeally. And this is the anterior arc of C1. And this is the upper fossa joint of C1. This is the lateral mass of C1 on right side. In the anterior approach, we succeeded to remove all of the bone structures between C1 and C3. And after then we implanted the 3D printed process between the occipital condyle to C4. And CT scan showed the 3D process in very good position. And this is CT scan after operation. And this is MRI after the second operation. The patient recovered very well after operation. No neurological symptoms, and because the upper cervical anterior approach is very less invasive, so the patient recovered quickly. And this is 3 months after operation. And but if the tumor not only located in upper cervical spine, but also skull base, and destroyed the skull base, there is no way to reconstruct the anterior column of CVG region. So we just use a posterior approach and very strong internal fixation system to build the stability between of the CVG region. For example, this is a female, 40 years old. He suffered a chordoma in CVG region. And we can see the tumor is very large and destroyed the clavus and the occipital condyle on bilateral side, and also C1 and C2. With the so severe destroy of the skull base, we cannot rebuild the anterior column of this region. We can see the 3D CT scan showed how severe of the destroy of bone structures. And and pathology is chordoma. With a posterior approach, we also with a extreme lateral approach to remove the tumor with only posterior approach. And in the first step, we can change the position in the operation. And first, we dissected the left C1C2 from the front via posterior approach. And second, we free and displace the right vertebral artery. And in the third step, we separate the tumor from the ventral border of the dural matter. In the fourth step, we separate the carotid artery and vein from the tumor border along the retrofrontal space. And step 5, we resection of the lateral tumor to normal bone of the left side. And then we implanted the posterior internal fixation system. Because in this kind of patient, we cannot reconstruct the anterior column. We should use a very strong posterior internal fixation system to maintain the stability of the cervical region. The normal internal fixation is not strong, so strong enough. So we designed this kind of four-rod system to reconstruct to enhance the posterior stability. And this is after operation. We remove the tumor with the posterior approach, and we implanted this kind of four-rod system. And CT scan showed there's a very small bone left in this region. And we can see we use this four-rod system to build the stability of CVG region. And the MRI showed there's no residue of the tumor. So, in conclusion, the treatment of upper cervical chordoma is extremely challenging, and it requires a combine of cervical approaches and reconstruction of the anterior cervical column with a 3D printed process provide a better solution. And of course, with only surgery procedure, we cannot cure this kind of patient. And so radiotherapy and chemotherapy, targeted therapy, also immune therapy is needed to prolong the survival of the patient. Thank you. Thank you for your attention.
Thank you, Zhen Chen. It was really an awesome presentation. I congratulate you for the cases that you showed us, a lot of discussion. As you showed us, these are really very locally aggressive tumors. And I think the first conclusion that we should draw from your presentation is that this kind of tumors and surgery should be done by very expert surgeons. It's a single shot surgery. It's much more difficult to deal with recurrences. So, especially for the young people in the audience, I think these tumors, they should be referred to centers where you have experts that can approach the neck from the front, from the back, be familiar with instrumentation. So this is really my first keynote. Something that you don't mention, and this is in line with what I said, do you think there is any role for biopsy to know what it is first before doing the surgery? Because there are different types of chordomas, of chondrosarcomas, different type of tumors. Sometimes some of them are more radio resistant, some less. Is there any role for biopsy when you face this not so typical images, and what are the cautions that you take?
Yeah, you're totally right. Biopsy is very important to it is very important. So for most patients, we will do biopsy. But usually this kind of patient, when they come to our hospital, about a lot of this kind of patients are recurrent after first surgery. So the pathology is we know it's a chordoma, and another several patients are so severe. They are so very severe pain or suffer the neurological symptoms. So we do not have time to wait for biopsy. And yes, for some patients, we do the posterior operations. Because for this kind of tumor in the upper cervical region, perform a block of this kind of tumor is not so easy. So for most patients, all of the patients we use a posterior approach, decompress at first and then with anterior approach to remove the residue of the tumor.
Yeah, exactly. And, the other thing is you showed us how difficult it is to remove those tumors, the piecemeal removal, because in this region, the unblocked resection is not so feasible. It's very, very, very hard to do it. But another thing that I liked in your presentation, it's the reconstruction. And we as surgeons or cranial-based surgeons, sometimes we forget to reconstruct. We think the most important part of surgery is the removal of the tumor, but it's not. As you very nicely showed, and this would be my second message for the young people in the audience, is you should care not only on take out the tumor, but also on how to reconstruct. This is great part of an excellent result, and this you excelled on showing us this. So I really like your custom-made 3D reconstruction, which is really stable. And also it gives you an idea of what needs to be removed, because once you remove the tumor, what you insert, the prosthesis should fit perfectly. So this gives you an idea, also very nice idea about what has been taken out and what needs to be taken out. Now I want to ask you more of the technical questions. Some of the first cases that you showed us a lot of transoral approach. And my question is, are these older cases? Some of those cases, would you do it with an anterolateral approach? Because with mobilization of vertebral artery from the transverse foramen of C1, you have a very nice exposure to the lateral wall of the upper cervical spine, and you can go really up far to the climax. So my question is, would you do the same again transoral, or are you abandoning transoral and doing more and more the so-called anterolateral approach that Bernard George described?
Yeah, you're right. Because I began this kind of operation 5 years ago. In the beginning, I use a transoral approach more, because the first several cases just located in C2, and the transoral approach is very convenient to expose C2, and we can directly remove the tumor, and it's very easy to implant as a process. But later, our cases is more and more complicated. It's located not in C2, but also in involved lower cervical spine. We have to use upper anterior cervical spine approach to remove this kind of tumor. And I found that most of anterior colon we can expose with upper anterior approach. So in these days, I use anterior cervical approach more and more. Transoral approach is very, very few because it's more less invasive.
Okay, excellent. And the other thing is, what you do the surgery? Do you consider radiotherapy for all patients? And my question is related to the fact that in a lot of the scans that you show, post-operative scans, there is a lot of noise from hardware. It's sometimes not easy to see if there was really a completely removal of a lot of artifacts from the prosthesis. So what you do normally to the patients? Do you send them to radiotherapy? Do you just observe them, knowing that imaging control can be difficult to assess because of the hardware artifacts?
Yeah, we cooperated with radiotherapy centers, and also several doctors help us to give the patient chemotherapy or targeted drugs. And even though a lot of patients, especially the recurrent patient, the tumor recurrence is still very quick. Most of the patients some of the patients recurrent only one and a half year after operation, and but because our cases is not so much, about 30 cases in this region. I have not followed this kind of patient long enough. Maybe the longest is no more than 5 years. But it's important to do the radiotherapy and the other therapy as soon as possible after operation. We usually give the patient radiotherapy 1 month after operation.
Okay, good. Thank you. The other thing is just another technical point for me to understand also. In most of your cases, you include the occiput in the posterior construction. And, of course, some of the cases I see the need for that, but in other cases where the tumor was sparing C1 and the occiput, why to include C0? Why to include the occiput in the construct? If C1 was spared and the occiput was spared, and there was no tumor above C1.
Yeah. Usually I just stop the fixation. If the C1 is not destroyed, we just stop the internal fixation with Appr to C1, not included the occipital bone. With my experience, it's stable enough.
Okay. So now, can I invite you to just to tell me your opinion about this case? The 45-year-old female, neck pain with this mass lesion here, and she has a prior history of breast cancer. And someone did the biopsy, and it was revealed to be a chordoma. So how do you do this approach?
Yeah, for this kind of tumor, it just destroys the anterior column, the water body of the C4.
Right.
And so I think, according to I think we use anterior port to remove the anterior column of C4 is enough.
Okay.
And usually we use a 3D printed process to rebuild the reconstruct the anterior column.
Okay. So we did it a little bit differently, and we supplemented also with the posterior, and that was an unblocked resection of the tumor with the control of the vertebral artery, and we supplemented with the posterior fixation just in case. Okay, it's a very easy tumor.
Excellent. Very excellent.
Anybody else has questions for Zen?
Yes, we can take a few questions, I think. But I'll start with me. First of all, let me congratulate Professor Zen for this wonderful management of such complex cases, and we had a great learning today. So thank you very much. Regarding the timing of surgery between the when you have a staged surgery, you go anterior and then on a later you come to posterior to in this stage surgery, what is the time duration between the two surgeries? Is it in this next day, same day, or you stage it at a later date?
If the tumor is not so large, for example, only C2 or on we can use with only with perform the post approach and anterior approach with one stage. But if the tumor is involved multiple vertebral body, for example, if C1, C2, or 3 level is involved, if we use the CT scan before operation to rebuild the 3D process, when we perform the post-operation and then we turn the patient around to perform anterior approach, sometimes the process is not suitable. And the operation is too long. With the post approach, maybe 5 hours, 6 hours, and anterior approach, another 6 hours. So for in these days, if the tumor is involved multiple vertebral body, we use the posterior approach first. After posterior approach, and then we give the CT scan for this patient and use the post-operative CT scan to build the 3D print, to design the 3D printed process. And it need 1 week to finish to build the processes. And then 1 week later, we do anterior approach to remove the anterior column and reconstruct the anterior column with a 3D printed process.
Thank you very much. We can invite our Honorable Prof. Cordoba. Would you like to say something?
There are very difficult situations to solve this kind of tumors, but the main concept, I think, is the resect and reconstruct. This is very difficult, but I think we must do by the very, very expert surgeons.
Thank you. Is my co-host Libun saying?
Yeah, thanks, Raja. Thanks, Prof, for a very nice lecture. I would like to ask you 2 questions. My first question is, thank you for showing us the four-rod technique for the posterior reconstruction instrumentation. And you showed that the media 2 rod was attached to the hospital plate and cross-linked with the one fixed. My question is, the reason to have 4 rod as you do not intend to have posterior fusion, and you want to increase the strength of the rod so the patient doesn't need fusion. Is that the reason? Secondly, your 3D print mesh catch, do you allow to put in bone chips or bone matrix to allow a fusion, anterior fusion, or you don't intend to have anterior fusion too? If both do not intended for fusion, how long do a patient need to put on a rigid collar? Thank you, Professor.
Thank you for your question. And with the 3D printed process, we did not plant bone graft in it, and we just use this kind of device to rebuild the anterior column. In our experience, it's very stable, and it can furend in the upper surface and the lower surface with the bone structures, and very stable. Because this kind of 3D printed process, we do not only use this kind of tumor cases. We also use other cases if we perform ACCF, we just use this kind of 3D printed process. It's very stable, and it's especially suitable for the tumor cases, because without a bone a bone graft, we can decrease the recurrent rate of the tumor. And for several cases, even the tumor recurrent, even the adjacent bone structures are destroyed. This 3D printed process is still stable at there, and keeps the cervical spine in the good station. So with my experiences, this kind of process is very suitable for the tumor cases. Thank you.
Yes, Prof. Since we do not need to look for fusion, do we need to apply a rigid collar post-operatively, Professor?
Excuse me?
To put on a hard collar for the patient after surgery. Since we are not looking for fusion, do we need to have hard collar, Professor? Thank you.
This process, fusion with upper surface and the lower surface, we do not know how long, but usually we give the hard collar for this patient only 3 months. After 3 months, he can remove the collar.
Thank you, Professor.
So, well, thank you very much, Prof. Zhan Chen and Prof. Oscar Alves for this wonderful session about very complex surgeries for upper cervical chordomas. It was very interesting and we are extremely grateful to you for this wonderful session. Now I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Alvaro Cordoba and Professor Zhan Chen, as well as the chairs, Professor Sanford Su and Professor Oscar Alves, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and special thanks to my co-host Dr. Liu Bun Seng and all the other attendees, Dr. Ben, who joined me today. So until we all meet tomorrow online, it is bye-bye from all of us. Thank you very much for joining.